My name is Michael Muhonen. I am a neurosurgeon at Children's Hospital of Orange County, and I have been at Children's Hospital of Orange County for about 30 years. So I am a pediatric neurosurgeon. I have been doing this since 1993 when I finished my training. I pretty much since high school always wanted to be a neurosurgeon. One of my younger brothers was hit by a car when he was 4 and I was in high school, and a neurosurgeon took care of him. And basically I said to myself, wow, I could take better care of this child than this doctor, because he never comes and sees us till 10 o'clock at night. Then he only spends 30 seconds with us. So it somewhat motivated me. Obviously the interest of the brain and the science interested me, but I was struck by the fact that he was so busy and so overwhelmed that he couldn't see you till late at night, and then you only got a short window of time with him anyway. So typically the day would start at 6, and you would you go in the hospital, you want to be there by 6:30 to see the patients from the day before, patients that are traumas in the ICU. And you'll typically meet your physician assistant or the students and the residents. You'll see the patients in the hospital that need to be seen on a daily basis. Surgery then typically starts at 7:30. Do surgery till maybe the afternoon. In between surgeries, you'll typically see a patient that's been put on the schedule to be seen urgently. And then after your surgeries are done, I would have, if my surgery finished at 2, then I would have maybe 10 patients scheduled from 2 o'clock until 5 o'clock. And then once the office is closed, you go see the patients that you've operated on that day again, check on them and make sure that they're not having any problems, and check their blood work. And some of them have had CAT scans and MRIs, and you want to check those. And then there's always some paperwork that's left over from the office, and that's probably the biggest nuisance that physicians face today, is that everything is electronic. So you have to do all the computer work and the billing charges and the notes in the computer. It used to be, when I started, you just wrote it by hand, and it was fast and quick and easy. But now you have to enter the computer data, and that's been difficult from a time perspective. And then by that time, it gets to be 7, 8 o'clock at night, and you wind your day up. Depending on how many are in your group, you're going to be on call, so you have to man the emergency room. It's usually dealing with a patient death. Yeah, I have done, the number was like 10,800 procedures, and I cannot recall the majority of those, but I can certainly recall the ones where patients died, and I can recall the entirety of the procedure where a patient died. Yeah, the struggle is, how do you get back up on the saddle and do a procedure after you've had an outcome that's not desirable? And that's the hardest struggle, I think. So you have to have a strong ego, and you have to have trust in yourself. I have a couple of them, not just one proudest moment, but one is I got to walk one of my patients down the aisle when she got married. She didn't have a father in her life, and that was a very proud moment. Other proud moments are when students that have followed me and were thinking about going into neurosurgery have graduated and become neurosurgeons, and that's now happened 3 times in my life. So proud because I knew that I made an influence in their life in a positive way, that they were going to pursue this career and just, try to be like Mike, and those were proud moments. So the debt load of a typical neurosurgeon right now is going to be about $300,000 to $500,000 when you're done with all of your training. And you have to look at from a financial perspective. Well, I'm going to make $500,000 every year for the next number of years that I work. So it's overwhelming if you stand back in the middle of it and say, I'm a $250,000 or $500,000 in debt. But you can't do that. That's way too overwhelming. But that should motivate you to finish, knowing that you've created such a tremendous amount of debt also. But in the big picture, you're going to recover it. It's kind of like, planting the seeds for the harvest in the fall. That's all you're doing, is buying all your seeds and planting them, and that student debt is seed money. That's how I looked at it. I don't want to discourage anybody, but it takes a long time. So you complete high school, you're 12 years of high school, 12 years of school, including high school. Then after that, you need to go to the university or college for about 4 years. And then you go to medical school for 4 years. So there's 8. And then you do an internship where you learn the doings of a hospital for a year. And then you do a residency for about 7 years. So it's 4 plus 4 plus 1 plus 7. So that's 16 years right there. And then you typically, if you want to do children, add on another year or 2. So there's 17 years after high school of training that's required to become a pediatric neurosurgeon. And you're overwhelmed if you stood back as a high school student and said, wow, that's going to be 21 years from now. But when you're in the middle of it, it's, college goes kind of slow and medical school goes fast and residency goes very fast. And before you know it, you're there. The drawback is you're not really getting paid during those 17 years. So you kind of get your first job when you're like 34 years old rather than when you're 19 years old. And I think, like anything else in life, the more education you get, the longer you postpone your first paycheck with more degrees, the more monetarily rewarding it is, and gratifying from the perspective you put in all this work, and now you're put in a position of trust because you've put in these 34 years of work, that somebody would trust their child for you to open up their head. You would have to really love money to stay in the field only for the money. But that being said, I know some people that have had that attitude and done it. And those same people have always left the field early. They tried to make their money fast and then leave the field rapidly, because you don't have a motivating force to drive you to do neurosurgery once you've achieved the monetary reward. So everything's getting smaller and more precise. It used to be, if I wanted to take out a brain tumor that was, say, right here near the speech area, I would open up the head, yay, and a big question mark. Well, now the computer, it's called stereotactic computer, can tell me, well, the lesion is right here instead of right there. So now I only have to open the head like this, because I can precisely know where this is based upon the computer guidance. Before, it was an estimation. So incisions have gotten smaller. The other treatment is gene therapy and putting viruses in the brain that carry a new genetic content that it can pass off into the brain to reverse pathological states. So the best summary is that things are getting smaller, things are getting more precise. Neurosurgery was a very macro field when I started 30 years ago. Now it's a very micro field with smaller incisions and a more precise attack of the pathology. Neurosurgery still cannot be done by a robot. It's not something that it's too fine and precise, I think, to trust a robot, but it wouldn't surprise me if it evolves into that eventually. The problem you have is you say, okay, well, a robot to do the procedure, it can't stop a bleeding artery, for example, like we can. We have a little cautery device, and if it bleeds, we just buzz it and stop the bleeding. And we just don't have the precision with any robotic surgery yet. You can take out like a gallbladder with robots, and the surgeon's running it with robotic arms, but we don't have that expertise yet for neurosurgery.